Well, we're back, just like we threatened to be. And usually when I have the break, I think of a few things I want to ask you, but actually there was nothing. I think things went very smooth in the first half. I always do ask, however, did you hear me well and continuously in the first half? Good. And another thing that came to my mind, we're playing Journey songs today, and that beautiful voice that you heard in the group Journey, one of the greatest rock groups of all time. His name was Steve Perry. And of course, he's in the Rock and Roll Hall of Fame. And one of the reasons I like Journey so much also is because if you've ever seen a picture of Steve Perry, and if you've ever seen a picture of my nephew, they look like they're twin brothers. So whenever I see my nephew, I say, "Hey, Steve, how are you doing?" Okay, let's get down to some serious business now. And I said first half, but we probably really did a little bit more than half. So let's pop up our PowerPoint again, and this is where we are going to continue now for about a little while, maybe 20 more slides. I know I shouldn't think quantitatively, but I do. And when you go to lectures, and sometimes if you're being bored or if you just want to get out, or maybe you're just getting tired from listening so much, you always want to know how many more PowerPoints there are. So let's talk about one of the main topics here of hemorrhage. You know what hemorrhage is? It's bleeding. It's actually when the blood, or you have extravasation of the blood beyond the blood vessel, whether it's artery or vein, capillary. A generalized bleeding disorder, very often resulting in is called a hemorrhagic diathesis. They often use the word hemorrhagic diathesis when a person basically bleeds out, especially if he has a clotting disorder. Another term that's commonly used clinically, radiologically, pathologically is hematoma. It means there's been extravasation of hemorrhage, but it implies that there's a mass effect. So this increased amount of localized blood is exerting a mass effect, just like a tumor or an oma would produce a mass effect, okay? Often they'll use the word dissection of hemorrhage, and that's strictly resulting from the fact that when you have bleeding and there's extravasation, the blood that leaves the blood vessel can actually dissect, or let's say invade into the surrounding tissues. That's a dissection of hemorrhage, or dissection in an aneurysm, let's say within the wall of an aneurysm. You should know from the purposes of size only that there are three types of hemorrhage if you want to look at it from the point of view of a size. The word petechiae, whether you see it on the skin or whether you see it in the mucous membranes or whether you see it surgically, is usually a pinpoint area of hemorrhage, no more than about 1 or 2 millimeters. So when you see somebody with little red dots, you could say they're petechiae. Now, most commonly, petechial disorders are due to problems with platelets, either low platelets or abnormally functioning platelets. When the same amount of hemorrhage now is bigger than the petechiae, but it's less than 1 centimeter, very often is called purpura, purple, although it's a purple blotch that is less than 1 centimeter. And now when you have a purpura that's greater than 1 centimeter, 2, 3, 5, 10, 20, that can be called an ecchymosis, which is another name for a bruise generally. And just like we defined water as being in different body cavities, now if you have blood in the thorax, it's called hemothorax. Remember, we say if you had water, you called it hydrothorax. If you have blood in the pericardium, that's called hemopericardium. If you have blood in the peritoneum, that's called hemoperitoneum, or perhaps even hemorrhagic ascites, okay? If you have blood in the joint space, that can be called a hemarthrosis. And of course, the hemorrhage can be acute, fresh, recent, where the primary product are red cells or perhaps even slightly degenerating red cells. But in chronic hemorrhage, you usually have the red cells which are now chemically changed, perhaps the perhaps the hemoglobin has now undergone chemical degradation to various forms of bilirubin, which would make it greenish yellow, or perhaps blackish, which would be hemosiderin, which is now probably going to be chewed up by the macrophages. So an acute hemorrhage would technically be red. A chronic hemorrhage, if you look at the evolution of a bruise you might have on your skin, it goes from red or purplish to green to yellowish to brown or black. Okay, so you go from hemoglobin to bilirubin type compounds, making it green or yellow, to hemosiderin, making it brown or black. Okay, that's the evolution of hemorrhage within often visible. Here's just some clinical examples. There's a bruise, ecchymosis. There's a hemorrhage. Because it's largely under the nail, you might call it a subunguinal hemorrhage. There's a larger bruise. There's a collection of blood in the brain. This might behave like a tumor. That's why this might be called a hematoma, but any collection of blood which may or may not have a pressure effect would be called a hematoma. And there's some tiny little hemorrhages on the inside of the bowel. Could you call those petechiae? Yeah. Could you call those a purpura? Maybe, depending on their size. I think most people would call these petechial hemorrhages because most of them are pinpoint and small, even though some of them are bigger than a couple of millimeters. Here's some hemorrhage in and around the brain and surrounding structures. There's some collection of blood. It looks like it is above the dura, so you might call that epidural. If you have a collection of blood under the dura, that's called subdural. Most epidural hemorrhages are arterial, and they involve fractures of the overlying skull. And most subdural hemorrhages are not usually due to skull fractures, or there they could be, but they involve venous blood because there are venous sinuses between the dura and the underlying brain, which of course is technically close to the subarachnoid space. But there's another type of hemorrhage called subarachnoid hemorrhage, which, as you might guess, would be arterial hemorrhage because the subarachnoid space is where all of the bigger cerebral arteries run. And of course, if some of those bigger cerebral arteries hemorrhage in the brain, that would be called intracerebral or intraparenchymal. And if you keep following this anatomic journey, if you had hemorrhage within the ventricular system, that would be called intraventricular. And where primary intraventricular hemorrhage is not too common in adults, it's one of the most common types of hemorrhage in premature babies with severe problems, okay? There's some hemorrhage as a surgeon might see it. Not only is it within the wall of the bowel, but it is in terms of clots that have leaked out and accumulated within the abdominal cavity. The clot itself could be nothing but a collection of blood, but the clots, of course, can also develop their own technical organization and inflammatory changes, and they could be firmly adherent to whatever they are next to them, not dissecting it, but adherent to it, clinging to it, because now you have those same principles that we talked about of inflammation and organization, making that clot adhere to the surrounding structures. If this is just blood that has been dumped into the abdominal cavity, it might look like jelly and it wouldn't adhere to anything. But if after some period of time, perhaps days or longer, weeks even, it might adhere to the surfaces and you wouldn't be able to pull it out so easily. From a CT point of view, and of course you know this is CT, not MRI, because the densest portions are the bones. You could see a kidney here, you could see a liver here, you could see a spleen here. Oh, but look, you got a nice comparison. Here's a kidney in which you could pretty well see some differentiation between the cortex and the medulla, but in this kidney, you look like you have a significant separation of the substance of the kidney. And you would think, well, if this is somebody that has had maybe some trauma or gunshot wound, you are now looking at hemorrhage within the kidney. And I know what you're thinking. You think, hey, well, isn't there hemorrhage within this big spleen as well? Well, you know that's not true. You know that this actually is the stomach, which very, very often conforms to the curvature of the spleen as well. So we have a renal hematoma here. Here's hemorrhage in the brain. Or did I say in a brain, or did I say peripheral to the brain? And when you see something like this, you know this is not CT anymore. This is MRI, because the brightest signals on this particular tweaking are the fat of the scalp. But now you see some compression of the brain. And if you could see an intact dura somewhere, you would probably call this subdural. And if you see that there was an overlying skull fracture, you could technically have epidural hemorrhage compressing the brain. But if you did that, then the dura would be underneath the hematoma and not above it. Okay, and it's always, you know, for a long, long time before we had CT and MRI, it was always a big, big, big problem as to whether the hemorrhage was epidural or subdural. And now it's like a piece of cake. Any radiologist could tell you in 2 seconds. Now, we talked about a hematoma being a collection of blood. We talked about a clot being a collection of blood, but not necessarily evoking a pressure effect. But you have to remember there's 2 kinds of clots also. There's the postmortem clots, and there's the premortem clots. A premortem clot is a clot that forms before the patient died. A postmortem clot is a clot that forms after a patient dies simply because of the settling of blood. Now think about it. How do you know the difference? Well, there's various terms given, but technically a premortem clot, something that formed before, perhaps long time before the patient died, would probably adhere to whatever is surrounding it, like maybe even the lumen of the blood vessel. Whereas a post-mortem clot, because it's just settling of blood, can be very easily separated from the tissue that's surrounding it. And it's given various names, like this one has more of the consistency of jelly. They often call a they often call a post-mortem clot currant jelly or chicken fat, whereas a premortem clot is more solid. What is hemostasis? Well, now that we talked about hemorrhage, let's talk about hemostasis. If you think because the word stasis is in there, it refers to sluggish blood or static blood or blood that's not flowing. That's not true. Hemostasis is a term that could generally be regarded as the opposite of thrombosis, or it's the process by which the liquidity of blood is preserved, okay? But you can also have hemostatic plugs at sites of vascular injury. It's really one of the most confusing words, and if there was a better one to use it, I probably would. But now, when we talk about hemostasis, all of the components that preserve the fluidity or the liquidity of blood, you got the main thing being the delineation of the blood, which is the vascular wall, and technically the brains of the vascular wall, the single, often tiny, thin endothelial cell. You have the platelets, which are basically going to be activated if there's a failure in that system. And then finally, you have your coagulation cascade, which strengthens the platelet plug. So now we're starting to talk about the opposite of hemostasis, which is thrombosis. Okay, so what happens when there's been a vascular injury? Well, probably the first thing that happens is that there is a arteriolar vasoconstriction. Isn't that nice? Because now we got blood vessels that are damaged, vascular injury, and you think you'd probably want to close those off with a tourniquet, but your body has a better way of closing it off. It basically makes a substance, several substances, but the main one is endothelin, which you might guess were from the endothelian cells, endothelial cells, and that is a very, very powerful vasoconstrictor at the arteriolar level. You can also have a neurogenic type of arterial vasoconstriction as well. Now, if the endothelium is damaged and it is not separating the blood from the connective tissue of the underneath the endothelium, okay, you now have adherence and activation of the platelets, and the end result would be a platelet aggregation, or what they call primary hemostasis, or you might call it primary coagulation. When the platelets interact with the endothelium, a very powerful coagulant is made called tissue factor, which basically gets the coagulation cascade rolling, the big cascade of events of factors and cofactors, which will eventually result in strengthening that platelet plug of primary hemostasis, and now a fibrin network called secondary hemostasis. If that sounds pretty bad, I think the next few slides will kind of basically summarize it better. The three players of coagulation are the endothelial cells, which every blood vessel has, whether it's an artery, a vein, a capillary. Okay, it is the first part of the cell to actually be in contact with the bolus of blood. You have your platelets inside of the blood bolus. And then when the coagulation, when the vascular wall is damaged and you have your aggregation of platelets, which is called the primary coagulation or primary hemostasis, you now have your classical coagulation cascade sequence, which strengthens that with the ultimate product now being generated as fibrin. So in primary hemostasis, your ultimate endpoint is a platelet plug. In secondary coagulation, your primary product is fibrin. So let's talk about the endothelium. I always talk about the endothelium as being like Dr. Jekyll and Mr. Hyde. Okay, I actually had somebody contact me a couple days ago, one of the medical students, and they say, endothelium is like a woman. If you're nice to her, she does all these wonderful things for you, but if you disrupt her or mess with her, she's going to be your worst enemy. And probably Jekyll and Hyde is also a really good thing, because normally endothelium does everything in the world to protect the fluidity and the liquidity of blood. It normally makes compounds which are anti-platelets, so the platelets don't stick to each other. It normally makes things like heparin-like compounds, which are anticoagulants. And if there is fibrin, it also makes fibrinolytic properties if it's normal. If it's activated or it's injured, it then is your worst enemy. It goes from the good Dr. Jekyll to the evil Dr. Hyde, and it does everything the opposite and it does before it's messed up. It now has a bunch of pro-coagulants properties. So let's look at it. I mean, we talk about endothelium so much. Let's actually look at it. There's a small blood vessel, maybe it's a capillary or an extremely tiny venule, probably a capillary, because the main component of it, of this thinned out cytoplasm, is the cytoplasm of an endothelial cell. Now there's an endothelial cell nucleus, there's an endothelial cell nucleus, and as you can see, in a small vessel capillary, you have basically tiny little junctions between the cytoplasm of the endothelial cells. And in some capillaries, you actually have spaces in there, what they call fenestrated capillaries. But look, you know this is a capillary here because it's not really much bigger than this little deformed, normally deformed blood cell, and there's a blood cell there. And look, now you have technically little lumps or stretched bands of endothelial cytoplasm forming the wall of this tiny blood vessel. So this endothelium actually protects anatomically the blood from the connective tissue underneath the endothelium. Okay? It also makes things which degrade ADP. Now, if you might remember, ADP is a substance that platelet makes, from the delta granules, and it actually promotes platelet aggregation. But the endothelial cell makes things which degrade the ADP, which is like inhibiting aggregation. Endothelium also makes heparin-like molecules, which is a powerful natural anticoagulant. It also makes a substance which encourages protein C to do its job, which is also a powerful natural anticoagulant. And if you remember, there is a pathway in coagulation called a tissue factor pathway, which we're going to see soon, and I mentioned already. It also inhibits the tissue factor pathway because tissue factor, which is a compound made by virtue of platelets and damaged endothelium, is one of the primary initiators of coagulation. And endothelium itself also dissolves. It makes fibrinolytic compounds, okay, which actually promote TPA or tissue plasma, whatever. Okay. So when the endothelium now is activated or messed with or promoted, or we have it making von Willebrand's factor. And as you know, von Willebrand's factor basically combines the platelets with the collagen, okay? It also makes tissue factor rather than inhibiting it, okay? And with the platelets, endothelium makes tissue factor being the strongest procoagulant substance known to man. It also makes plasminogen inhibitors. So if plasminogen are basically dissolving fibrin, we now have something which inhibits the dissolving of fibrin. The best word to describe what the endothelium does when it turns into Mr. Hyde is the word disruption, endothelial disruption. What are the things that could disrupt endothelium? Well, it could be bacteria, okay? Especially many of the gram-negative bacteria can disrupt or mess with endothelium. Even hemodynamics itself. If you have an abnormal type of non-laminar blood flow or stasis, or what they call eddies, or what they call lack of uniform, smooth, liquid flow, turbulent blood flow. These are also things that could activate endothelium. It could be activated by many things within the plasma. And also, remember, what about physical trauma? If you traumatize a blood vessel, aren't you also traumatizing the endothelium? Of course. And so these are all the things that could disrupt or activate endothelium, from the wonderful Dr. Jekyll to the evil Mr. Hyde. Platelets. Platelets themselves have a bunch of granules inside of them. You'll never see them on your office thing, but if you look at a platelet, it doesn't have a nucleus. But what it does have, if you look at it under electron microscope, are granules. There are dense granules, which conveniently are called delta granules, and there are alpha granules, which are not quite so dense. And of course, they're going to be making a lot of the coagulation factors, like fibrinogen, factor 5, factor 8, another thing called platelet factor 4. Okay, these are all basically things that the platelet makes, which will ultimately not only be part of the coagulation cascade, but also enhance their aggregating to each other. ADP, okay, is a big product, the main product of the delta granules, and that is a strong factor in making the platelets adhere to each other. Now, the platelets with the endothelium now make tissue factor. And I've already mentioned this 3 times, and pretty soon you're going to see a chart, like you'll see many charts of the coagulation cascade, in which the tissue factor is the prime mover of the extrinsic coagulation system. Well, here's platelets. That's a megakaryocyte, which you might say if you look at a bone marrow, it has a nucleus, but the cytoplasmic parts of the megakaryocyte pinch off these tiny little platelets. They are anucleated. Platelets are anucleated cells, but even though they don't have nuclei, they do have a bunch of granules. The ones that are really black are called delta or dense, and the ones that are not quite so black are called alpha. Okay, those are a lot of deltas in there and a few alphas. And I think I actually have something here which I made a few years ago, which might help you to visualize how these granules get expressed. And so I'm going to do this and see what happens. There you go. There's a granule. Looks like it's pretty dense, probably a delta granule being protruded, okay, during the time that the platelets are activated. Okay. The platelets first adhere, okay, to the extracellular matrix, which is a result of a damaged endothelium. They then secrete various compounds from these granules, okay, not only many of the coagulation factors, but also things which help them to aggregate to each other to form the platelet plug. The platelet plug is the end of the first phase or primary phase of coagulation. It is measured by a test called a bleeding time. So like when I cut my lip today, or my cheek when I was shaving, in about 3 or 4 or 5 minutes it stopped. It's not because I had fibrin, it's because I had the platelet plug. However, compounds from the platelet granules will then kick in the part of coagulation phase 2, where you have the production of fibrin. Okay, so your platelets adhere primarily to the subendothelial extracellular matrix. Why? Because the endothelium is disrupted, it's activated. It's also regulated by von Willebrand's factor. If you remember, there's a von Willebrand's disease that people have, which resulted in bleeding. But if you have von Willebrand's factor, you can bridge platelet surfaces, helps to bridge it to the extracellular matrix collagen. There's your granules, alpha and delta. For those of you that are big chemistry fans, the process going on in platelets, which causes them ultimately to secrete, is a process called phosphorylation by virtue of kinases. You remember kinases are enzymes which phosphorylate compounds. So that's basically one of the big functions there. In platelet aggregation, you have the production of ADP from the delta granules, adenosine diphosphate, which is the biggest factor in aggregating platelets. Another one is thromboxane. Remember, one of the prostaglandin-like compounds, or thromboxane A2, which is also pro-thrombotic. And of course, thrombin, the second to the last product in the coagulation cascade, also helps platelets to aggregate. And fibrin strengthens the platelet plug and makes it hard. So primary hemostasis is just a big platelet plug, and secondary hemostasis is a platelet plug strengthened by fibrin. In the platelet events, at first you have adherence to the extracellular membrane, then it's secreting these prothrombotic proaggregation compounds. It exposes the phospholipid complexes, remember, phosphorylation. It then, with endothelium, expresses tissue factor, and now your primary plug becomes a secondary plug because the secondary coagulation came in and produced fibrin and strengthened that primary plug. Okay, I know I threw a lot of stuff at you, okay, and I know I've showed you this chart before, but I think you should have a good understanding. I don't think it's very hard to memorize big charts, but I always chose the chart that was not too easy and not too complicated. So let's talk about the actual final phase of coagulation, which is the production of fibrin. There are two ways it starts. One of them is what they call the intrinsic arm, which basically starts with factor 12 as a proenzyme, and a more direct and usual, probably more common way is the production of tissue factor from platelets and endothelial cells. In the coagulation cascade, you have proenzymes, which become enzymes, and then those enzymes act on other proenzymes, which become enzymes, and it's a cascade, a sequence of events, which we've seen before, with the ultimate final product of thrombin converting fibrinogen to fibrin. Now, if you think that's the end of it, you could probably think it is, but there are secondary things that are now could happen to strengthen the fibrin or to dissolve the fibrin. Remember, we talked about endothelial cells having compounds which dissolve fibrin, and then there's this whole concept of natural anticoagulants which keep a check on this whole cascade. Calcium enters into it. We talked about phospholipid from the platelet membranes. And remember, some of these factors are made in platelets, in the alpha granules, but some of them are made in the liver. And I think you should know, I think you should remember this, that factors 2, 7, 9, and 10 are not only made in the liver, but they are dependent on vitamin K. So a vitamin K deficiency for any pathophysiologic reason might result in not enough factor 2, 7, 9, or 10. Also, liver disease, okay, because this happens in liver. Liver disease might result in these deficiencies. A very, very good reason why people with liver disease might have a hard time coagulation and therefore bleed as well. There are also compounds made in the body, factor S, factor C, Z, which are also made in the liver, and rather than accelerating coagulation, they keep a check on coagulation. So both thrombotic precursors as well as anti-thrombotic precursors are present in the liver. Here we go. We saw this before. Let's look at it again. You have the two arms of the coagulation cascade. Remember, this is the final phase of coagulation now, the production of fibrin, which is right here. You have factor 12 being converted to factor 12A. You have a proenzyme going now into an enzyme, which is now enzymatically converts factor 11A, the proenzyme, into an active enzyme 11A, which then enables factor 9 proenzyme to go into 9A, which with the help of the activated factor 8 now produces factor 10 proenzyme into being 10A. And of course, you're near the end now, because now 10A is perverting thrombin, factor 2, prothrombin, into actual thrombin, which is the active compound, the final active compound to convert fibrinogen into fibrin. And fibrin then can stay as nice, it can become cross-linked, it become straightened, but it can also become dissolved by a process called fibrinolysis, which is another cascade as well. You should also know that these tiny little red lines, I don't know if you could see them, but protein C, protein S are basically compounds which keep a regulation or a check on coagulation. So you don't, it doesn't get out of control. You could say that these compounds are the primary controllers of it. Now, we just talked about basically the intrinsic or the left side or the left arm of the coagulation cascade. It looked like it was kind of complicated because look at all these steps. But look, if now you look at the other side, which also ultimately results in fibrin, you have the tissue factor or the extrinsic pathway. Remember, we said that platelets and endothelial cells make tissue factor? Well, look, tissue factor then could directly convert factor 7A, which is the active enzyme, from factor 10 to X. And now you only have 2 steps. Up here you have about 5 or 6, but that's why it's always talked of as the so-called extrinsic pathway or the tissue factor pathway being more powerful and more direct than the intrinsic pathway. Now I know I just said a lot, and I know this chart may look complicated. Maybe you have to look at it again, but we're going to be bringing this up in many other chapters, especially the ones that might involve bleeding disorders or coagulation disorders. So over the years, I've seen a million different variations of the coagulation cascade. And when I started teaching this course, I thought, well, we should pick one that is not too complex and not too easy either. So when you are in practice and your anticoagulant salesmen come in and they try to sell you an anticoagulant drug, they're going to be, and when you go to meetings, you're going to see all kinds of variations of this complex cascade here, but I think this is the best one. Finally, your surgical patients will, in every routine hospital admission, often involves routine coagulation tests. Okay, well, the first thing is a platelet count, okay? Every patient that comes into the hospital gets a CBC. They count the platelets automatically, and they should be between about 150 to 400. If they're much lower than 150 or even much lower than 100, you got a problem with potential spontaneous bleeding. If you have more than 400, maybe 1 million, you got problems with perhaps thrombosis. You know, you can measure somebody's fibrin or fibrinogen by an easy assay. You could even measure all of these different factors, but they're usually not necessary. Because if you do a test called the activated partial thromboplastin time, it measures this intrinsic pathway. So you've got any problem here in this 5-step process, you're going to have an elevated, activated partial thromboplastin time. It is a good general measure of the factors of your intrinsic coagulation arm. It's also something that helps you monitor the effectiveness of your heparin therapy as well. So if you're anticoagulating a patient with heparin, you want to do this test to see if it's being anticoagulated enough. Probably even something that's even more commonly done is now called INR. And it is basically a modification of the old prothrombin time, okay? And it's basically a prothrombin time relative to controls. So this measures the INR, the extrinsic, which is over here, arm, which you remember is the more direct arm. So patients that are on Coumadin therapy are monitored with INRs. And you know, if you know, it's not easy to keep it within that normal range of about 2. If it's higher than that, you got to make sure you have to give them less Coumadin. If it's lower than that, you might want to give them more. It can be a very, very complicated process. Now, you automatically know what a normal platelet count is. But if your platelet count falls below 150 or more likely lower than 100, it's going to result in an increased bleeding time. Why? Because there are not enough platelets to make the plug. And a normal bleeding time is about 2 to 9 minutes. That test is done less now than it used to be, but it's still done because you could have a normal number of platelets with an elevated bleeding time simply because the platelets are not working properly, or what they call a qualitative platelet disorder rather than a quantitative platelet disorder. So these are all common coagulation tests that can be done. Some of them are done routinely, not only in just pre-surgical patients, but in almost all hospital patients. And we're going to end it here today now. Thank you, because the second half had a lot of complex stuff in it. Sometimes I would like to ask if it was too overwhelming for you. And I know that nobody's going to say it was too easy.